Okay, right now, Dr. Gary Siskin is going to come up, and he's going to give us an overview of just kind of the basics of CCSVI. Dr. Siskin is now at about, what, a little over 500 patients? About that, yeah. And he has a study that he's getting ready to start. So, go ahead.
Sure, thank you. There's a lot of people here. And it's a hard talk to put together because there's a lot of different people here. I'm assuming that this audience consists of some treated MS patients, perhaps, and some untreated MS patients. I'm sure that there's friends of MS patients and relatives of MS patients, and there may even be members of some anti-CCSVI Alliance people here. And I think we all have Sharon and the CCSVI Alliance to thank for bringing us all together so we can... I'm not going to go into things that I'm sure you already know. You know how chronic and disabling this disease is, and you know how many people are affected with MS. I'm sure you also know that most people today think there's an autoimmune component to MS, and that other theories that have certainly been floated around include some environmental theories, infectious theories, and some genetic theories as well. But really, we're going to talk about something completely different. And it may be different, but it's really not exactly new. As Mike Dacus talked about many times, there have been people through the years, such as Dr. Charcot or Putnam in the 1800s and 1900s, who theorized about a possible relationship between the cerebral veins and the inflammatory lesions associated with MS. And through the years, there's been pathologic observations about this relationship. There's been functional observations about this relationship, and certainly there's been many imaging observations that have all supported the idea of there being some venous abnormalities potentially associated with multiple sclerosis. It really took Dr. Zamboni in Italy to kind of put this together and come up with this theory of CCSVI. So, because I think everybody in the room thinks he's pretty important, we'll turn him to black and white, so he's kind of classic like the other people. And, you know, what we're doing in terms of what this is really all about is conceptually we're talking about a venous obstruction that's involving the veins that drain blood from the brain and the spinal cord. It's not, a lot of people get confused sometimes, it's not about the blood going to the brain and the spinal cord, it's about the blood coming from the brain and the spinal cord. And so what we're looking at are essentially two sets of veins. The first set is the jugular veins, and they're the principal veins that we think about from vampire movies, the large ones on both sides of the neck, and they're chiefly responsible for much of the blood flow from the brain. We're also looking at a vein that no one's heard about, a vein called the azygos vein, which is kind of right here in the yellow circle there, and it's the vein that is one of the veins that are principally responsible for ultimately draining blood from the spine and the spinal cord. And so that's why we're focusing on those veins. They're the veins that are really responsible for bringing blood from the brain and the spine. And so when you look at kind of this view, so if we think about the internal jugular veins, here's just a graphic representation of this vein. What we're looking at is a potential valve abnormality down here at the bottom of the internal jugular vein that really essentially narrows the room in that vein for blood to flow. So there's a bit of an obstruction there. What happens when you have an obstruction to flow is that there's just resistance to flow. And everyone here has really heard the term reflux. So in a perfect world, the blood is coming down from the brain through this wider part of the jugular vein. And when it hits this narrowing, what ends up happening is some gets through and some does what we call this little reversal of flow or reflux, which shows up on things like ultrasound and potentially on MRV to let us see that this condition is potentially affecting an individual that we're studying. Once there's this reflux and once there's this problem with flow exiting the brain, all of a sudden you have increased venous pressure in the vein. Increased venous pressure in the vein, and that can lead to a couple of different things, we think. The first is a blood-brain barrier disruption. So there's this concept that as the blood flows through the brain, there's the cells that are lining the smallest blood vessels in the brain are preventing everything from passing from the arteries and capillaries into the brain material. And if this is disrupted, then bad things can make its way into the central nervous system. The first is, and this is the classic CCSVI theory, is that red blood cells may pass into the central nervous system. That can lead to iron deposition around the nerves, and that's a lot of what Dr. Hackey's studying with his MRIs. And that leads to potential functional abnormalities with the nervous system. The second is really synergistic with what the neurologists are talking about. If there's blood-brain barrier disruption, it's certainly possible that this can be contributing to our own immune cells passing into the central nervous system, ultimately leading to the autoimmune response against myelin that's classically thought to be responsible for MS. The other thing that was recently discussed at the International Society for Neurovascular Disease meeting in Italy, held just a week or two ago, is there's the potential for decreased nutrient absorption. So what do I mean? Well, when the blood flows up towards the brain through this artery, and then passes through the capillary bed down into the vein, there's normally a decrease in pressure. So on the artery side, the pressure is high. On the vein side, the pressure is low, and that's what drives flow from the artery to the vein. If you have a stenosis of some sort or blockage in the vein, it's going to increase the pressure in the vein. So now the difference between the pressure in the artery and the pressure in the vein becomes not as pronounced. So you might have some decreased flow through those capillaries. That could lead to decreased nutrient absorption, and as was presented in Italy, that could potentially be contributing to increased fatigue or decreased mental acuity, which is often seen in MS patients. So just another theory as to why these things happen, but ultimately, the thought is that the increased venous pressure, almost regardless of which mechanism we're talking about, can lead to some of the symptoms that were classically attributed to MS, and in some circles there's even been some talk about progression, although I'm not sure I necessarily am in that camp, but certainly that's been discussed when it comes to MS. So I know that there are a lot of questions about this. And so we're going to talk about some of the questions and go through it a little bit. The first is, how do I know if I have CCSVI? Well, MR venography is probably the most prominent way, certainly with all the work that Mark's done, and it's terrific. There's great pictures. It can evaluate the veins. It can evaluate the brain. I know he's going to speak a little bit about this. It can evaluate flow. There's so much information to be gained from an MRV. I'm not sure we've yet defined false negative and false positive rates just yet. I think there's some work that needs to be done, but you certainly can't beat the pictures really in terms of looking at the veins. There's probably been a little more research performed on the role of ultrasound in diagnosing patients with CCSVI. We typically are talking about the classic Zamboni protocol, which looks at 5 different criteria, and I'm not necessarily going to go through them. I know there's a lot of information out there about that, but essentially he looks at 5 different things, and if at least 2 out of 5 are positive, then that patient is deemed to have had a positive exam for CCSVI and they have this condition. Now what you need to know is that there's a lot of controversy surrounding that. So the University of Buffalo group, so while Zamboni found that patients who had positive ultrasounds always had MS, that hasn't necessarily been confirmed universally. And so the University of Buffalo group found that 56% of MS patients had this problem, but that 22% of healthy patients also had this problem. And then, of course, DEP found that 0% of MS patients had a positive exam, and that led to a lot of controversy that people have really read about in newspapers and probably heard a lot about. The different results may be due to different technique and maybe due to different levels of experience, but at the very least, I think they show that not every patient with MS has CCSVI, and I think that's an important concept to kind of walk away from this from. There have been newer ways to diagnose CCSVI that have been discussed. There's been CT venography and cervical plethysmography. That's something that was just recently discussed in Italy. But at least for now, just speaking for our group up in Albany, we've been using ultrasound as our non-invasive test of choice right now. I think what most people agree on, at least right now, is that the standard is venography. And what venography means is that we're going to go inside the vein and take a look at what the vein looks like. So this graphical representation here is us putting a catheter, which is a tube about the size of a piece of spaghetti, into the femoral vein by the hip and threading it up using x-rays for guidance up through the heart right here, up into the veins that we're studying. And once the catheter makes its way into the internal jugular vein, we can take a picture. And this is kind of what we see frequently, this narrowing here down by the valve area just above the collarbone. And this is a picture of the azygos vein with a fairly extreme example of a stenosis in the azygos vein. You can see it almost looks like there's a twisting there. It's probably not really a twisting, but it looks that way, and so that's why it was described that way. So it has that twisted appearance. So the next question is, how do you treat CCSVI? And we treat it typically with angioplasty, meaning that we take a catheter that has a balloon built into it, kind of a sausage-shaped balloon, and we put it across the area of narrowing, and we blow up that balloon to get a picture like this, which means that we've kind of pushed away or somehow changed the nature of the vein to improve the blood flow from the vein. You should know that Zamboni, that a lot of what we're talking about here is really based on the original work of Zamboni in 2009, which treated 65 patients with CCSVI, and what he found was sustained clinical improvement in relapsing remitting patients but only limited improvements seen in progressive patients. And one of the important things that came out of his work is that at 18 months, only about 53% of the lesions treated in the internal jugular vein were open, and so that's why a lot of people talk about a 50% restenosis rate within 18 months, meaning that the vein may collapse, and that's the common terminology that a lot of people are using. But that's the basis for that kind of word that's getting passed around. The study concluded that treatment of CCSVI was safe and feasible, but that, remember, this was key. He himself said further research is necessary. And that's a very important part of this whole thing. There was a second study out of Italy which looked at 35 patients with fatigue, and they found significant improvement in many aspects of fatigue in MS patients with CCSVI. So that's kind of, there have been some newer studies that have been presented. They kind of send the same message, and thinking that maybe relapsing remitting patients may in fact be the best group of patients to treat, but I think there's a lot left to learn, and we've certainly seen really nice responses in patients with progressive disease, but also fatigue and changes in mental acuity seem to be one of the more common things that we're seeing in patients. So is this safe? Well, Ken Mandato, my partner up in Albany, presented some safety data that we put together on 247 procedures in 231 patients, and there was also a paper recently out of Dr. Simka's group in Poland looking at slightly more patients. And what he essentially found is that there's a low risk of major complications. So what we see most often in patients is a little bit of headache, a little bit of neck pain. It tends to go away in most people. Everything else really is rare. Remember, importantly, when I talk about doing a venogram, I mentioned that our catheter does go through the heart, and sometimes that can cause subtle changes in the heart rhythm. So it's important to monitor the heart during these procedures to make sure that that's okay. And really everything that we've seen has been treatable. We have seen some veins clot, so that's thrombosis, and within 30 days, if the numbers are low, and they're actually in agreement between the two series. We had one patient whose heart didn't react so well to this procedure, and the muscle got very thick, and it slowed down a lot, and she ultimately did fine, but it was a very worrisome and scary complication. And over in Poland, they reported about trouble even removing a balloon from a patient. So things can happen. I hate to have everyone leave here thinking that nothing bad can happen with these procedures. There's certainly, we all know that there's been some deaths reported. The ones that have been reported have been seen more in association with the drugs that are given after the procedure as opposed to the procedure itself. So I think we all feel that there needs to be some consensus reached amongst all of us as to which drugs are best to put patients on after the procedure. And so lastly, the last question I have is, should I have more questions? Well, the answer is, of course you should have more questions. Because as my little daughter would tell you, there's lots of things we don't know. We don't know exactly the answers about stents versus angioplasty, or big balloons versus small balloons, which everyone is talking about on This Is MS and various websites. Is it the valves? Is it the veins? You know, we talk a lot about it, and we don't have definite answers. We think it's more likely a valvular abnormality, but that's still an unanswered question. What about seeing patients who have recurrent symptoms? Do we wait? Do we retreat them? What exactly do we do? And again, what medications are these patients best put on? There's questions. There's actually lots of questions. And so you should have questions, we have questions. Research is really going to be key. I think the one thing that we know is whether it's YouTube or whether it's Facebook, what we know, all of us know who are here, is that we definitely have made many people feel better with this procedure. And right now, there's a spectrum between Zamboni's idea and this concept of broad acceptance of CCSVI. I think really we're living right about there on the spectrum right now, maybe even closer to just a proof of concept. And so the only thing that's going to get us moving in that direction is research. And so I cannot stress to you how important it is, you know, to kind of spread the word about getting involved in research protocols, encouraging people to do that, because for the greater good, we're really going to have to, you know, get people who are agreeable to helping us figure this out and to answer all your questions and to answer our questions as well. So in conclusion, CCSVI in general is clearly an exciting way of thinking about MS and the symptoms experienced by MS patients, but as I've stressed over and over again, there's a lot of work that needs to be done to answer all the questions remaining about CCSVI. So thanks.